Hello, my name is Gaurav, and today I'm going to discuss with you hydrocephalus in psychiatry. So, these are all the topics which are not generally covered in your clinics. So, that's why we thought in the form of tips that we are going to cover these topics so that they are useful for yourself in your exams. All right. So, in hydrocephalus in psychiatry, why should we care? Because, like, it might exacerbate psychiatric symptoms, and even it might exacerbate some of the cognitive disorders. And normal pressure hydrocephalus is one of the reversible causes for dementia. The psychiatric onset of presentations of these disorders, this is very well documented, and early recognition will obviously improve the outcomes. All right, like for example, these are some of the imaging. All right. So what is this? We'll just go there. This is flare image, okay? This is the frontal horn. All right, and it has impacted the white matter over here. It has impacted the white matter over here. So that's why this is again a case of hydrocephalus. Okay. Now what is this? This is again you see the boxcar ventricles, no? So these are all indicative of hydrocephalus. So this is T2 imaging. What is this? This is CT scan, again hydrocephalus. CT scan, hydrocephalus. CT with contrast, hydrocephalus. Then T2 MRI, again showing hydrocephalus in a lateral view. I'll tell you why these things are important once we go ahead in the presentation. All right. So what is CS? We just have the idea of like what is the CSF physiology. We know that, the CSF is produced, all right, over 150 ml of total volume of CSF is produced, all right, in the ventricles and subarachnoid spaces. And 400 to 600 milliliter of CSF is produced and absorbed in the entire day, all right? So this is the subarachnoid space. This is arachnoid granulation. These are the ways of absorption of CSF. So the absorption of CSF is by arachnoid granulation, and the production of CSF is by the choroid plexus over here. All right. So this is the flow of the CSF with the help of ependymal cells, and then it goes into your aqueducts. All right. All right. So these are the various areas where there can be pathologies. Like, for example, if there is excessive production, more than absorption, impaired absorption, hypersecretion in the choroid plexus, then your ependymal cilia, they are not moving. There are problems with the cerebral aqueduct. And because of the increased CSF accumulation, they can cause this something which is called as Hakim's triad. Okay, we are going to discuss Hakim's triad. All right. Okay. So these things which are seen in the hydrocephalus, the CSF overproduction. All right. So what we are going to do is like we already understood the CSF production. We are going to differentiate between the idiopathic normal pressure hydrocephalus from Alzheimer's, diffuse Lewy body dementia, frontotemporal dementia, frontal variant of Alzheimer's dementia, vascular dementia, and then we are going to also find the psychiatric manifestations, for example, cognitive, behavioral, and emotional symptoms which are across the groups, and the surgical treatments and how they might improve the psychiatric outcomes, the imaging patterns, some of the things which we'll learn over here. And we'll also understand how to track the patients, especially the pre and post shunt status in the cognition and behavior. All right. We see that these are the lateral ventricles. These are the lateral ventricles. So here the choroid plexus, it produces your, this is the choroid plexus. So what does it do? It produces your CSF. All right. And CSF goes into from the lateral ventricles into the third ventricle through which foramen? The foramen of Monro. And then it goes into the Sylvian duct and then through the foramen of Leschka and foramen of Magendie. The CSF gets absorbed. Okay. All right. So, okay, so this entire thing is in your diencephalon, your all the things, the thalamic structures and all, no? So there's this the entire thing is in between that. So, like generally the ventricles, they produce it, cerebral ventricles, they produce it, and then it goes into the spinal, and then it flows into the spinal cord, into the spinal and thecal sac. And like it's not just the absorption, it's just not the flow, but there's also another system, the parallel system which flows according with the CSF, which is the lymphatic system. Okay. So if the lymphatic symptom system is combined with your CSF, it becomes glymphatic system. And in the glymphatic system, if there's an impaired absorption, so it can lead to again the hydrocephalus. All right. So there are some things which are used by the radiologists. They are like even like not used very often by the radiologists unless they are doing the flow studies, but just for the purpose of the theory, we are just going to understand the phase contrast MRI. All right. So when the CSF flows, how do we determine that whether the CSF is actually flowing correctly or not? So there is a bulk flow, all right, and there's an oscillatory flow. So bulk flow is something which is normal flow. It's like 4 mil per minute. All right. It goes into the CSF gets produced into choroid plexus, ventricles, and subarachnoid space. And from production to absorption sites. So it's just the thing which just get produced and then it gets absorbed. So it is very less. It's around 4 mil per minute. And oscillatory flow is like a cardiac driven motion. Okay. So it's something which is like, from your brain, if it has to go to spinal cord and the speed has to increase, it has to be synchronized with your atrium. All right. So this is oscillatory flow. This is 700 mil per minute. All right. So there's a rapid to and fro flow from aqueduct to the foramina. All right. So phase contrast MRI helps in differentiating between whether it's an obstructive hydrocephalus, all right, where there will be more bulk flow, or there's communicating hydrocephalus where there will be more of oscillatory flow. All right. So there can be various pathophysiological mechanisms. So I've put various diagrams over here. All right, and we have already discussed some of the mechanisms. So this is the choroid plexus, all right, and this is the epidermal lining. This is the brain and vascular system. This is the glial mediated lymphatic system or the glymphatic system. Okay, and these are the meninges. Okay, so these are all the sites where like the things can be either there can be tumor or fibrosis or whatever the things they can be uh, blocked. Okay, so there can be obstructive hydrocephalus where there's like the blockage of the entire foramen of Monro, all right, or communicating hydrocephalus when the CSF when it goes back into your brain, here it is getting obstructed, or like but the thing is like normal flow is maintained from here. So that's again something which is called as the communicating hydrocephalus. And then there's a periventricular interstitial edema. All right. And then there's white matter ischemia. So there's something called as white matter ischemia. What happens in Alzheimer's disease? Now imagine this is the brain. All right. These are the ventricles. This is the brain. All right. And this is the skull. Okay. Around it. All right. So what happens in case of Alzheimer's? The brain, it gets shrunken, okay? It gets shrunken like this, okay? So it might feel that the ventricles are enlarged. How do we know that it's not enlargement because of the shrinking of the brain? It is a hydrocephalus. So there's a metric for that. That's called as a dash pattern, okay? So dash pattern. So we are going to just see those dash pattern in the next few slides. So there are some of the hypotheses for the hydrocephalus. For example, like people used to say that, uh, sorry, bad. Hmm. People used to say that it used to be a pressure problem, all right, but like a normal pressure hydrocephalus is not a pressure problem. Age-related ventricular stiffness, your pulsatility gets impaired. That can be one of the problems. Periventricular ischemia, again, the CSF doesn't get absorbed, gone. Glymphatic dysfunction, again, glial and lymphatic dysfunction, so that can also lead to the exchange is affected. Dash pattern. Dash pattern. What happens is dash pattern is like disproportionately enlarged subarachnoid space hydrocephalus. All right, we are just going to see this kind of pattern in the slides later on. How do we identify the dash pattern? All right. So ventricular expansion cycle, like the like first of all, like there's a small obstruction, all right, and then there's increased blood flow, the increased flow of fluid, increased fluid, increased fluid, increased fluid, so it can lead to the enlargement of the cerebral ventricles. So these are some of the mechanistic hypotheses for the hydrocephalus generation. So we already discussed some of the hydrocephalus over here. Like one of the things is the obstructive hydrocephalus, where there can be aqueductal stenosis, foramen of Monro blockage, and fourth ventricle outlet obstruction. Communicating hydrocephalus, which is because of subarachnoid hemorrhage or meningitis. all right, or leptomeningeal carcinomatosis, all right. Pardon me for these tongue twisters. Yeah. And then there can be the normal pressure disturbance, normal pressure hydrocephalus, which has this Hakim's triad, which includes the cognitive impairment, urinary incontinence, and gait disturbance. Or there's something called as the ex vacuo kind of hydrocephalus, where the brain is atrophied, or there's a neurogeneration degeneration. Again, it is not a true hydrocephalus, which we often see. What is this? This is a congenital hydrocephalus. All right. This is a enlarged, very large hydrocephalus over here. All right. You can see over here. It's a very, very large hydrocephalus because of some aqueductal stenosis, neural tube defect, or posterior for some malformations. You can name all of these things in your answer. So there can be very, very big fontanelli, macrocephaly, irritability, developmental delay. So if there's a ventricular megaly and associated abnormalities, please find these all things. Acquired hydrocephalus, we already discussed, like 20 to 30 out of 100 individuals, they have this acquired hydrocephalus. What happens is that there can be subarachnoid hemorrhage, or there can be meningitis, or there can be tumors like vestibular schwannomas, pineal gland tumors, metastasis. All right, so this can lead to the communicating hydrocephalus. For example, there can be the obstruction either at the foramen of Leschka, foramen of Magendie, and or there can be impaired CSF absorption at the glymphatic system. All right. So, what is normal pressure hydrocephalus? Normal pressure hydrocephalus is like you see the person can be wet, wacky, and wobbly. So this is the entire Hakim's triad. All right. So you have urinary incontinence, you have decreased attention span, and you might have ataxic gait. All right. So ataxic gait means like, you know, the it's a like the person will have difficulty in starting. There can be it has a dysexecutive syndrome in the cognition and urinary incontinence. At night, the person will keep on getting up and keep on going to washroom, the bathroom. All right. So you have to see that. And in 60 out of 100 cases, you see this triad, and it can be either idiopathic or they can be, you know, because of subarachnoid hemorrhage or meningitis, and treat the traumatic brain injury, which we see common in psychiatric scenarios, and it is something which is treatable. There are some indices, all right. So these indices I'm just going to like discuss just in a moment, all right. First thing is Evans index. Second thing, callosal angle, and third is a Desch pattern. All right, we're just going to discuss these all things. Evans index is like, I'll just discuss that in a moment, and then we are going to just a second. I'm just going to take those pictures here in front of you. Yeah. So what is this Evans index? You know, this frontal horn of the lateral ventricles, frontal horn of the lateral ventricles, you find the maximum dilatation. You take a measurement from here. All right. This can be done in the scan, all right, in the MRI scan. So one value is here. This is one value, lateral ventricle, all right. And then you see your skull, okay. You see where there's maximum breadth, where there's maximum breadth. Here is the maximum breadth, right? You can see this red arrow. Pardon, because I'm not able to move my hand over here. So you see based upon the cranial width, okay. So if it is more than zero point 0.3, if it is more than zero point 0.3, all right, so it means that the person has hydrocephalus. Second thing is callosal angle. Now, what is this callosal angle? Callosal angle is like what happens is that you get the coronal section of the MRI, all right? Coronal section of the MRI, C for C, callosal angle, and coronal section of the MRI. Then you see the anterior and posterior sulci, all right? And then you see the ventricles, okay? The ventricles, and you take an angle from here to here, all right? You take an angle from here to here, and normal angle should be more than 90-degree, okay? All right. But if the thing is, if it is more than less than 90-degree, then it is again hydrocephalus. It means that these have expanded and this has not expanded so much. So this is again a callosal angle. This is again something which is for understanding hydrocephalus. Then there's subarachnoid space disproportion. What happens is that this get dilated and this get more squeezed, okay? The sulci gets more squeezed and the ventricles, they get dilated. It means the ventricles are dilated, but but and this might lead to the hydrocephalus. So this is something which is there, which is for the understanding of the diagnosis of hydrocephalus. I've just discussed all of them. The size check is Ivan's already told you. Shape check, it is like carousel angle. And if it is in, there is some catch in the carousel angle. Okay, if the shape is less than 63 degree, it means that with the shunt, you're going to work out. It will work. Dash preparation is like disproportionately in large subarachnoid space, hydrocephalus. All right. So, what are the psychiatric manifestations? So, for the sake of convenience, we have divided psychiatric manifestations into cognitive symptoms, behavioral symptoms, and psychotic symptoms. Cognitive, we have discussed dis-execution, all right? Memory impairment, obviously, and speed is slowed down. Fluency might be affected later on. Behavioral symptoms, the depression, almost like it is apathetic depression, okay, which you find in the hydrocephalus, okay? So this is depression. All right. Depression plus irritability. Again, depression plus social awkwardness. Again, hydrocephalus has to be ruled out. Hallucinations, visual hallucinations. All right. Late onset psychosis. And the symptoms remit with the surgery. They all make a thing which is like the symptoms are secondary to hydrocephalus. How do you differentiate hydrocephalus from idiopathic normal pressure hydrocephalus from dementia? All right. In dementia, the idiopathic normal pressure hydrocephalus, you find the gait is something we have discussed, that Hakim's triad, no? So that Hakim's triad is there in the hydrocephalus. All right. Gait will be the first problem. Memory will be the first problem in Alzheimer's disease. Gait will be the first problem in the hydrocephalus. All right. The memory will start getting affected, whereas the executive functions will start getting affected over in the hydrocephalus. Apathy will be first seen. We see irritability more in dementias. So this is how we clinically differentiate the hydrocephalus from dementia. For example, like there's another study, all right, which I found out, which was done on 41 patients, and they found out that execution is affected in 90% of the patients, and like your 100% patients will have apathy. All right, so that is the importance of apathy. Now, what could be the mechanism for it? We see this hydrocephalus, and this might affect the diencephalon. So, what does it include? The basal ganglia, hypothalamus, amygdala, corpus callosum, thalamus, hippocampus, and cerebellum, and some other limbic structures. So what happens is there can be the dysfunction of the frontal subcortical circuit. The region which is involved in hydrocephalus, like proposally involved in hydrocephalus, is anterior cingulate cortex, because of which the motivation is observed. Okay, so even like if you see the fMRI patterns, you see these things like the bold sequence. When you see, there will be hypoperfusion in the anterior cingulate cortex and thalamus. All right. Psychosis, late psychosis. All right, 70 years old and suddenly person becomes psychotic. Please understand that that could be hydrocephalus. Get a CT done for that individual. Sleep disturbances are often seen in hydrocephalus. So if you have a person who has like psychosis plus sleep disturbances, then you're in the late onset. It's an alarm that the person might have hydrocephalus. The person might have frequent awakenings, reduced sleep efficiencies, excessive daytime somnolence, and perhaps the thing which might be affected is frontal subcortical circuit dysfunction, the brainstem which makes sure that your REM sleep is okay. No, that gets affected. It can lead to a lot of caregiver burden. All right. Like, for example, like once you develop hydrocephalus, 90% of your functions are gone. All right. Unless it is corrected. So it can cause a lot of stress. And even like there can be a big problem for the individuals. So early intervention is very important. All right. And education of the family is very important for this disorder. We see in infants like what is macrocephaly, bulging fontanelles, all right, irritability, vomiting, and sunset eyes, which is a criteria for hydrocephalus for individuals. Children, irritability. is the most important, followed by the dysexecution and learning developmental difficulties. If you see in children, there can be, the headache, then attention problems. So those things can be seen in the adolescents, all right? So there's also academic decline. The etiologies are spina bifida, posterior fossa tumors, infections, hemorrhage. All right. So there are some plans which I've seen in USA and UK. So these are called, this is again important for the psychiatric purpose. One of them is the early intervention for learning support, and that is IEP program and 504 plans. Now, what are these IEP and 504 plans? These are there in CTP. IEP programs are the specialized education, individualized educational programs. All right. So to make sure that they are fairly, to make sure that they are given more time, modified curriculum. All right. And so that's the individualized educational program. So what is this 504 plan? It makes sure that, like, first of all, like, the children can be easily accessed to the hospitals, and there should be fairness for the individuals who have this kind of disorders. All right. So accommodation means 504, and if you give the specialized instructions to the students, then this is the IEP program. In adults, this thing, a normal pressure hydrocephalus presentation, like if it is hemorrhage, then it can be obviously, that you have this subarachnoid hemorrhage, thunderclap headache, cognitive slowing, tumor, you have to think about vestibular schwannomas and pineal gland tumors. And delirium, again, there can be obstructive lesions. So urgent imaging is required. Okay. We already know that the phenotypical variation is like the gait disturbance, and 6 to 12 months it takes from gait disturbance to going to cognitive decline. And then again, it takes like some time from cognitive decline to your urinary incontinence. That's the progress of the illness. So the early intervention will improve the cognitive delay, behavioral dysregulation. The dysexecutive function with adults should improve. Apathy in the elderly will be improving. But the thing is, like, you have to, like, do it on time. Otherwise, the white matter gets damaged, and then we can't do really much. So what is the thing? So this algorithm I made to understand, like, what should a psychiatrist do for the hydrocephalus. First of all, like, do a thorough physical examination in all your patients. Okay. Then there are some tests. Okay, some of the people discourage that, but I would still say that please do a thorough examination. Then do this MMSC, MOCA, ACE, trail making, verbal fluency, and cognitive function. And third is imaging. All right. So the three things, which are just three things which we discussed, are Evans index, callosal angle, and Desch pattern. Everything has to be checked in hydrocephalus. All right. So these are some of the things, like, you can take a picture of this, the comprehensive assessment, how you have to do. All right. Then there are some gait and balance tests. One of them is timed up and go test. All right. So and the gait speed, it is point less than zero point 0.8 meters per second. Stride length, short stride, turning test, multiple steps to turn 180-degree, magnetic gait. The feet appear stuck. And post CSF taps test, if the CSF tapping improves the individual, then again it is going to be better for confirms the diagnosis of hydrocephalus. All right. The imaging, we have already discussed all of them. There are some other things, aqueductal force studies. There are some cis tests, cis and space things again. So we already discussed this is your constructive, it's a constructive kind of imaging, and space is your sampling perfection with optimized contrast. All right, just remember these names. And we know what the person is improved if the person we use the CSF tab. And if the person is, like, not improving with CSF tab, like, then we have to do extended lumbar drainage for 72 hours, or we do a callosal angle and dash, like, we can see the, like, just see the callosal angle and dash pattern to see whether the person is improving or not. All right. So we have already discussed the symptoms and psychiatric differentials. Late onset psychosis, treatment resistant depression, cognitive impairment and motor signs, rapid cognitive decline, personality change, headache, nausea, papilledema. Do a fundoscopy in all of your patients. All right. So there are other disorders also. One of them is the idiopathic intracranial hypertension. The other is the spontaneous intracranial hypotension. All right. So it's idiopathic intracranial hypertension is like something which is just like hydrocephalus, but the thing is like it's in the women of childbearing age. All right. You have the pulse papilledema and field loss defects, whereas spontaneous intracranial hypotension, it is seen in your orthostatic headache. All right. So if it is the pachymeningeal involvement or brain sagging or subdiadural corrections, then you have to then there can be spontaneous intracranial hypotension. All right. So surgical treatments, we know that there are the ventricular peritoneal shunt is very common. Then there's a ventricular atrial shunt that is also something which is used. Endoscopic third ventriculostomy. You go into third ventricle and make a hole into that. So that's also used. Choroid plexus cauterizations is something it is used, and in 90% patients improve in terms of gait, all right, and cognition, 30 to 70% will improve. There can be complications of the surgeries like infection or obstruction, over or under drainage. So these are some things which can be done with the experience of the surgeons. Psychiatric, we have to diagnose it, all right. You can help with some of the education, and but the thing is like the education is important and identification is very important for psychiatrists. The medicines, like not much literature we have, I just found out from some of the articles like venlafaxine for as an antidepressant or SSRI like sertraline. Then antipsychotics you can just use olanzapine or aripiprazole. For cognitive decline, because of severe cognitive decline, you can use Memantine. And others is just make sure that you think about 100 times before considering ECT. All right. So this is a multidisciplinary team. All right. So we have to see. So these are summary points. Like we have to, how do we diagnose hydrocephalus? CSF TAP test. All right. And then surgical management, psychiatric management, and how to maintain an interprofessional care. Thank you so much for patiently listening to me. I know this is a different topic from what we usually discuss, but this is like how we are. All right. So let's hope this is going to be useful for exams. Thank you.